series or session of our oxygen therapy, oxygen series, care of pediatric and adult patients. Today we're going to be talking about oxygen therapy in adults. We have a wonderful panel for you today. Dr. Sara Miller-Strowd, Anesthesiology, Perioperative and Pain Medicine, Stanford Global Anesthesia. Dr. Anna Crawford, Anesthesiology and Critical Care Medicine, Stanford Global Anesthesia. Dr. Diana Hylton, Critical Care Medicine at Stanford Global Anesthesia. And Dr. Jennifer Taylor, Anesthesiology and Operating Room Management, Stanford Global Anesthesia. Thank you so much, everyone, for joining us this evening. I'm just going to run through a few of the Project ECHO guidelines before we get started with our session.
I'm going to start sharing my screen. And again, we're using our website that was sent out for this session. So in this first video, if you can write in the chat box what you see, and then we're going to talk about a case discussion, an adult with hypoxemia. Okay, so can you guys describe what you saw? It looks like that patient was in respiratory distress, which we're seeing a lot of. He's breathing very heavily. Feel free to write anything in the chat box. Okay, we're going to go on to the next, which is a case discussion.
Let's use a real-life case to discuss the care of an adult patient with hypoxemia. A 58-year-old man presents to the emergency department with 3 to 4 days history of fever, mild shortness of breath, and a dry cough. He denies any exposure to COVID-19 and has been practicing social distancing, wearing a mask, and hand washing. His past medical history includes HIV. He's on highly active antiretroviral therapy. His CD4 count is 245, and his viral load is less than 20. He has no past surgical history. He does not smoke. He is married with 2 children, and he works painting houses. What are the first steps you will take to care for this patient? What is your differential diagnosis?
So what is your differential for this patient? Pneumonia. COVID-19. Anything else? Okay, we'll keep going.
Diagnosis. The first step is to ensure all care providers are in full PPE for contact, droplet, and airborne precautions. Then, isolate the patient away from other patients. A procedure mask or double layer face covering should be placed over the patient's nose and mouth. Next, a physical exam and assessment should be performed, starting with vital signs, including pulse oximetry. Supplemental oxygen should be provided immediately, even before pulse oximetry, because the patient is showing signs and symptoms of respiratory distress. During physical assessment, providers should pay close attention to the patient's breathing status, including respiratory rate, work of breathing, whether there is accessory muscle use, and whether the patient has the ability to speak in full sentences. A breathless patient, breathing quickly and unable to speak in full sentences, will need a higher level of support than a patient who is breathing comfortably. Differential diagnoses include, but are not limited to, pneumonia, pulmonary edema, congestive heart failure, asthma, or drug use. Respiratory failure can be either hypoxemic or hypercarbic in nature. This is a triage tool developed for use in suspected COVID-19 patients. It uses both clinical signs and pulse oximetry to assist providers in triaging their patients. It is available on the Learning Resource Center and also on the Lightbox website. Answering the first question for our patient, he does have a fever, cough, shortness of breath, and a respiratory rate greater than 22. He does not have emergency signs of obstructed, absent breathing, severe respiratory distress, cyanosis, shock, coma, or convulsions. Using this triage tool, the next step is to measure our patient's oxygen saturation using a pulse oximeter. This patient has hypoxemia, as measured by the pulse oximeter. His SpO2 is 79%. Although his respiratory rate is slightly elevated at 24 breaths per minute, he is speaking in full sentences. His heart rate and blood pressure remain stable.
Okay, how would you support this patient? Would you give this patient oxygen? Okay, you would give them an oxygen mask. What else might you do? Would you place this patient in isolation? Okay, an ABG test. What would you gain from the ABG test? Would you place this patient in isolation? And would you do any further imaging? Okay, we'll keep going with the video.
How will you support this patient? Using the triage tool, because the patient's oxygen saturation is less than 94%, you would provide oxygen by nasal cannula or nasal prongs at a flow set to 5 liters per minute. It is reasonable to wait 15 minutes to recheck the SpO2 to assess whether the oxygenation has improved. When rechecking the pulse oximeter, the goal oxygen saturation is greater than 90% if there are no emergency signs observed. However, if at any time the patient's clinical status worsens and emergency signs are apparent, then vital signs and SpO2 should be immediately rechecked. When a patient has emergency signs, the vital signs should be rechecked every 2 to 5 minutes, and the goal SpO2 should be increased to greater than 94%. Emergency signs include obstructed or absent breathing, severe respiratory distress, cyanosis, shock, coma, or convulsions. Once a patient is on oxygen, is without emergency signs, and has stable oxygen saturation greater than 90%, then vital signs should be reassessed every 4 to 6 hours. Oxygen flow should be titrated up or down to keep the SpO2 between 90 to 96%. This is unless the patient is pregnant. For pregnant patients, the goal SpO2 is between 92 and 96%. For our patient, let's assume 15 minutes later you recheck the SpO2 and it reads 89%. Now, what steps will you take? According to the triage tool, this patient should now be placed on a non-rebreather mask with a reservoir bag. Oxygen flow using this device is set between 10 to 15 liters per minute. Non-rebreather masks can deliver inhaled oxygen concentrations between 60 to 95%. If your facility has an oxygen concentrator, it is your responsibility to know the maximum flow of the concentrator. Many oxygen concentrators are only capable of flows up to 10 liters per minute. If your patient still does not improve, then what will you do next? Once a patient requires a non-rebreather mask at high flows, the bedside
Okay, your patient now is on a non-rebreather at 10 liters per minute. His SpO2 is 90%. What are you going to do next? You can type it in the chat box. Keep the mask on until the oxygen level is greater than 94%. Okay, anyone else? Okay, Diana, tell me what you're worried about the patient.
The patient seems to still have a lot of problems getting oxygen, and we've escalated our level of support from nasal cannula up to the non-rebreather. So I would be very worried about the patient, that they might need even more support to keep their level of oxygen at an appropriate level for life.
All right, and let's keep going on the case discussion.
Bedside provider should be prompted to contact the ICU or next higher level of care if available. If the patient fails to improve with this level of oxygen supplementation, then he or she may need non-invasive ventilation or mechanical ventilator support. For the patient in our case, he is placed on a non-rebreather mask at 10 liters per minute flow. On recheck, his oxygen saturation is 90%. The next steps involved in caring for this patient should include vigilant monitoring, preparation for higher level of care, and consideration of awake-prone positioning.
Okay, can you guys answer this question? Is the statement true or false? An increased work of breathing with a respiratory rate of 27 breaths per minute is always an indication for oxygen, for supplemental oxygen support. Okay, the answer is false. Increased work of breathing is not always pathologic. The best example is increased work of breathing during exercise. However, if it is increased work of breathing is not sustainable or is associated with impaired gas exchange, then oxygen therapy is indicated. So we'll go over some of these oxygen delivery devices. This is also just further along on the page on the web sheet. So I'm going to share my screen. Okay, so a nasal cannula. Diana, is this generally the first thing that you go to for patients?
For a patient that is not our patient, that would just be in mild respiratory distress, this would be a standard first option, basic oxygen delivery.
Okay. And one of the questions we got were, what are the modes of administration for oxygen therapy? That's what we're going over right now. We've gone over this before in previous sessions, but these are the different types of delivery things that you can use for oxygen. So a nasal cannula delivers flows from 28 to 40% of oxygen and generally gives 1 to 5 liters per minute. A nasopharyngeal catheter. So this is not frequently used. Diana, do you use these in San Diego?
We don't use these for adults. I think for children, they might be used more often, I believe, but we don't typically use these where I practice currently.
Yeah. So this generally is only used in children, and it can deliver an FiO2 of 45 to 60%. and 1 to 2 liters per minute. It's generally in an infant and child. This is a simple oxygen face mask. You can get 6 to 10 liters per minute and 40 to 60% of oxygen. And then this is what we call a non-rebreather. So these are used for adults and children. There's a bag attached to it. You can deliver 10 to 15 liters per minute and get an FiO2, the fraction of inspired oxygen, of 60 to 95%. The bag serves as a reservoir bag of oxygen. Okay, and then we have the Venturi oxygen mask. Which can give you a precise amount of oxygen. And then some of the other questions that we got, we can just answer these along the way. What is the role of hyperbaric oxygen therapy in the management of hypoxic pneumonia? So this has actually been coming up quite frequently in the WhatsApp chat box that we have. So there's no evidence that hyperbaric oxygen therapy is effective in managing COVID patients or pneumonias. There's no current evidence of that. And also, the access to hyperbaric oxygen, that type of device, is extremely hard to get. Do you have any availability in San Diego to get that? Because we don't have any availability of that at Stanford.
We do have the availability of it, and it's we have a special service and it's in one of our hospitals. However, it's not something that we're able to access easily. It's a special team, and their hours are quite different, and they're typically for prearranged indications such as wounds, and there's only a few emergency situations that they're called for, but not typically a COVID and not typically pneumonia.
Great. Okay, and our next paper is on the oxygen wall chart. So this is a chart that you guys have seen in the previous ones, and it's oxygen therapy with limited resources. So it kind of goes through what you do if you have a COVID patient. And to walk us through this, you would see if the patient looks like they have COVID. Does it look like they have a pneumonia? Do you have a test that's available? And then you should immediately start isolation and using PPE, which is personal protection equipment, if available. One of the questions was, should you use high-flow nasal cannula in a COVID patient? Does anyone want to answer that? Anna or Diana?
Hi, Sarah. I can answer that one. Hi, Diana. So early in the course of responding to COVID-19, we were hesitant to use high-flow nasal cannula in patients because the high level of oxygen flow can cause viral aerosol. So can be a risk to the bedside provider. Now that we have had COVID for several months, although we realize that having viral aerosol is a risk to the bedside provider, that it is likely better for patients if they can be managed on high flow oxygen. versus being intubated and mechanically ventilated. So we have to take precautions to protect bedside providers. So when a patient is on high flow nasal cannula, we will often place a procedure mask over the patient's nose and mouth, and all bedside providers must be in full PPE for contact, for droplet, and for airborne precautions. So we use high flow nasal cannula very often now in our COVID patients, but we just have to ensure that the providers are safe. So making sure we have PPE available.
Great.
I would also just say that high flow nasal cannula, sometimes if people are unfamiliar with that device, might think that it's just a regular nasal cannula with high flows of oxygen, and that's incorrect. That high flow nasal cannula is not only a specialized cannula that goes into the nose, but it's also a specialized machine that generates very high flows, sometimes up to 50 or 60 liters per minute. So that if your oxygen supply is not plentiful, it will actually run your oxygen supply out very, very quickly. So it may not be an appropriate resource to utilize in all settings.
Okay, perfect. Thank you. Another question we got, and anyone can answer this, is an expensive pulse oximeter really much better than a $20 fingertip ones that we get locally made in China? These local ones seem to work pretty well, but some don't trust them and they easily break. Any advice or experience? Same for high flow nasal cannula.
I can attempt to try to answer that. We use the expensive ones probably more so in the hospital, but I also have used the portable ones with much success, and I think that they are also accurate. I think with any type of device that one uses, you have to know how to tell that it's not working appropriately. And sometimes with the smaller ones, you can't see a waveform that shows you that there's adequate blood flow and that it's sensing it all appropriately. But I certainly think that having any pulse oximeter over having nothing is a huge benefit. So I think that I would use them 100% and would trust it, but knowing limitations always.
Yeah, perfect. I would agree that frequently, as long as you have a good waveform, and we went over that in a previous section, that you can trust the pulse ox. They don't have to be expensive pulse oxes. Okay, so we can continue on with, I'll share my screen again. Okay, so the oxygen wall chart. Again, this is oxygen therapy with limited resources, and it's COVID-19, severe acute respiratory infection and pneumonia. So once you diagnose this patient and probably you have a laboratory test, or hopefully, then you should put a simple surgical mask on the patient. You should start infection prevention and control. Consider PPE and disinfect medical equipment and have dedicated COVID hospital spaces. Again, the respiratory signs and symptoms are an SpO2 of less than 90%. A child, again, SpO2 less than 90%. And many of the questions said, well, when do you actually start oxygen therapy? So here's when you start it. You start oxygen therapy if the SpO2 is less than 90%. And then people say, well, okay, well, how do you choose which device you use? Frequently, we go to nasal cannula or a face mask and nasal prongs for a child less than 5 years old. And your target should be the SpO2 greater than 90%. You can try the prone position. You can try that while the patient's awake. And that means placing a pillow under the chest, but they're still awake and they're just prone, which means the belly is down. And if the SpO2 is not greater than 90%, you can try advanced oxygen or ventilator care as needed. So again, this just reviews the oxygen delivery devices that we were asked about. And this also goes through how you can decontaminate and disinfect. So that includes physical cleaning, and this is the preparation of the 0.1% sodium hypochlorite solution. So again, in low resource settings, you frequently don't have a lot of, the oxygen delivery or the tubing. So it's okay to use that on multiple patients as long as it's disinfected in between. Do we have any questions about that? And panelists, do you have any other comments on that use of oxygen or COVID?
I would just say that there's several questions about how much oxygen to deliver, which oxygen delivery device to select for patients. And much of that depends on the patient's requirements. And the patient's requirements are determined using a pulse oximeter as well as physical exam. If the patient is in just respiratory distress, they may need more oxygen than someone who is breathing easily. But the best way to determine whether or not a patient needs oxygen is really to use a pulse oximeter. And then the oxygen delivery device, as you nicely outlined, each device delivers a different level or fraction of inspired oxygen concentration. So the lowest oxygen level being delivered would be something like a nasal cannula. The next lowest would be a simple mask. And then if you needed to deliver more oxygen, then you would move toward a partial rebreather or a non-rebreather. And those oxygen masks have that oxygen reservoir bag. And then the Venturi mask can also deliver higher levels of oxygen. So I think one important point is to realize the goal SpO2 and to deliver the right amount of oxygen. So not too little, but also not too much, because if you deliver too much oxygen to one patient, oxygen is very expensive and sometimes has limited supply. So you want to make sure that you're delivering the appropriate amount to each patient so that you can actually treat more patients and not use all the oxygen on just one patient. Similarly, when you use one oxygen delivery device, such as a nasal cannula, it's the maximum liters per minute on a nasal cannula is around 5 to 6 liters per minute. So you don't want to use flows higher than that, because it would be wasteful, because the oxygen then just leaks out of the system and into the environment and actually isn't helping the patient. So I think it's important to go through that chart and recognize how much flow you should use for each device and if that's appropriate for the patient. And how you determine if it's appropriate for the patient is by using your pulse oximeter. Also important, once you have a patient on oxygen, to continuously monitor using pulse oximetry. As that patient improves, you can actually start to titrate down the level of oxygen. So if you start off on a non-rebreather or oxygen mask with reservoir bag at 10 liters per minute, and your patient's saturation is 100%, then you may want to you may want to decrease the oxygen delivered, and that may require a different device or just a lower level of oxygen.
And when do you decide when to intubate a patient?
So I would always err on the side of being very safe and calling or notifying your airway team earlier rather than later, because sometimes it takes time to get medications and equipment ready to support a patient who's in respiratory failure. Intubation is usually indicated for patients who are unable to sustain their gas exchange on their own. So hypoxemia or low levels of oxygen, hypercarbia or high levels of carbon dioxide, or an unsustainable work of breathing. So a patient who's breathing very quickly, a patient who is fatiguing, who's not able to speak, has all of the other clinical signs and symptoms of hypoxemia and respiratory distress. And if you begin oxygen therapy for those patients and it doesn't make them better, then you need to move quickly to the next highest level of support. So if you're on a nasal cannula, you want to move quickly to a higher FiO2 using a NonRebreather or high-flow nasal cannula or non-invasive ventilation if those things are available to you. If those things are not available to you and you're on an oxygen mask at the highest level, then you need to actually have your airway experts come and evaluate that patient soon.
Okay, and we're going to share a video about airway management prior to intubation. So if the patient's not looking great and you've decided that you're going to intubate, as Anna has gone through those signs, we'll just go through the airway management, and let me share my screen.
Before considering intubation and mechanical ventilation, providers must first recognize respiratory distress. Respiratory distress can lead to respiratory failure, which is a failure to maintain adequate gas exchange of oxygen and carbon dioxide. Regardless of cause, patients in respiratory distress need support. Providers of all training backgrounds should understand how to support patients' breathing until intubation and mechanical ventilation are initiated. Remembering the indications for intubation and mechanical ventilation can help providers recognize the respiratory problem and intervene appropriately. Many times, patients have more than one indication for respiratory support, and multiple interventions must occur simultaneously. If the patient is hypoxic, they need supplemental oxygen therapy. The provider must monitor using pulse oximetry and decide which oxygen delivery device is most appropriate for the patient. Remember, adult patients can receive supplemental oxygen by nasal cannula, simple face mask, non-rebreather face mask, or Venturi face mask. If the patient is obtunded, is hypoventilating, or is apneic, they will also likely have hypercarbia and may need manual or mechanical assistance with breathing. If the patient is hypercarbic, the cause is usually hypoventilation or apnea. These patients can be obtunded from high levels of carbon dioxide, so providers need to assist these patients with carbon dioxide elimination. This can be achieved using manual ventilation with a bag mask device or by applying non-invasive ventilation support such as CPAP or BiPAP. If the patient is oversedated, leading to hypoventilation, then reversal medications should be considered. These patients require supplemental oxygen as well. Patients can have increased work of breathing for many reasons. However, if the increased work of breathing is not sustainable or gas exchange of carbon dioxide or oxygen becomes compromised, providers must lend support to the patient. These patients usually need both oxygenation and ventilation assistance. Additionally, the obstructed airway needs to be opened in order to get oxygen in and carbon dioxide out. Providers must also recognize when their interventions are successful or not. If the patient improves with any of the above interventions, then the provider must continue to closely monitor the clinical status. If the interventions fail to correct the problem, the provider must quickly call for help and continue to support the patient until intubation and assisted ventilation can occur. The first step in airway management is recognition of respiratory distress or failure. Once recognized, the provider must quickly apply oxygen and pulse oximetry. This should also initiate a call for help. If the patient is not breathing adequately to maintain oxygenation, then manual assistance of breathing is indicated using a bag and mask device. If the airway has obstruction, then it must be opened using the head tilt and jaw thrust, or by inserting an oral or nasopharyngeal airway device prior to bag ventilation. Oxygen flows on the bag mask device should be at 15 liters per minute. If the provider is still unable to ventilate the patient despite previous interventions and the airway provider still has not arrived, then they should consider inserting a supraglottic airway such as an LMA. Once the LMA, or laryngeal mask airway, is inserted properly, the bag ventilation system can be used to support the patient's breathing. If the respiratory failure is unlikely to resolve quickly, the patient will need intubation and to be placed on a mechanical ventilator for support. In an emergency, opening an airway and assisting a patient's breathing is more life-saving than intubation. The provider must open the airway and maintain a good seal on the face mask to ensure each manual breath enters the patient's lungs. Opening the airway involves pulling the mandible or jaw up toward the mask. It does not involve pushing the mask down onto the face. If the provider is unable to maintain a good seal with one hand, they should ask for assistance and perform a two-handed technique. Providers must watch for chest rise and fog in the mask to ensure sufficient breath delivery. If you do not see chest rise, the breath is not entering the patient. Inserting an oral airway can also assist in holding the tongue forward during bag mask ventilation. Excessive pressure or ventilation against a closed airway can lead to gastric insufflation and an increased risk for aspiration. LMAs, or laryngeal mask airways, are designed to be inserted without using a laryngoscope or visualization device. These devices are inserted blindly. By design, once inserted, these devices will seat around the larynx and direct the incoming breaths anteriorly toward the trachea.
Okay, do we have any questions about that video? So one of the questions that Anna actually just answered that we had is, what is the minimum oxygen therapy requirements before an anesthesiologist arrives? Now, this isn't necessarily the minimum, but it says if the patient is on an oxygen mask reservoir bag at 10 to 15 liters per minute, then an airway team, an anesthesiologist, should be notified. So when the patient is requiring that amount, it's likely that they're going to require intubation. And at that point, an anesthesiologist, at the very least, should be notified. And
So Christian is asking a very good question.
Is PEEP only applicable in mechanical ventilation?
I would say that's the most common situation in which we think about PEEP, but it is applicable in other situations. When you use the bag mask manual ventilation setup, you can sometimes insert a small valve that's called a PEEP valve, so that if you maintain a good mask and you're manually ventilating, you can maintain a small amount of PEEP that way. Also, when you do non-invasive forms of ventilatory support, such as CPAP, BiPAP, those devices also generate PEEP. So it is applicable in other settings. I think one other thing is high flow nasal cannula, because it is such high flow, there is thinking that it does generate a small amount of PEEP. However, it is that the level of PEEP generated is unmeasurable, but the thinking is that it also generates PEEP. Diana, do you have anything different on that?
No, I think that covers it all. I completely agree.
And you can also, you know, even when you don't have a full breathing tube and you're placing an LMA, if you have a good seal on the LMA, you're able to apply PEEP through the ventilator as well. Okay. We will, we're just going to show you the Lightbox page again, which goes over a triage tool that was again shown in the video. So midway down, it shows Lightbox triage tool, tells you how the pulse oximeter could be helpful in COVID-19 decision making. You can download this in multiple languages. And again, this was reviewed in the video that we went over in when to provide oxygen, how much oxygen, what your goal SpO2s are. And maintaining it. So one of the questions asked, how do you decide when to discontinue oxygen? Do any of our panelists want to answer that question?
I can attempt to answer that. It's going to be very different for every patient, depending on the level of oxygen support that they're currently requiring. And if the patient is on a mechanical ventilator, typically the oxygen level is slowly walked down from initial fraction of inspired oxygen delivered of being 100 back down to around 30%. And when the patient is requiring less oxygen support, such as 30%, and your level of PEEP that they're on is low, then you start to think about whether this patient needs a mechanical ventilator anymore. And you could consider taking them off a mechanical ventilator. The patient may not be on mechanical ventilation. And if the patient's simply on a non-rebreather and their pulse oximeter is showing a saturation of, let's say, greater than 98% the majority of the time. And even if you don't have access to an ABG, you can simply follow this pulse oximeter and slowly walk the level of oxygen support down. I think it's something that has to be evaluated quite frequently for every patient, so that, as Dr. Crawford was saying, that we don't leave patients on too much oxygen, as it's very expensive, and your supplies, they can become depleted quite fast when patients are on a lot of oxygen. So evaluating and watching a pulse oximeter and how much level of support they're on, and that's how you can slowly walk it down. just as you walked it up, you watch the same monitors is what I would say.
And are there any side effects of having too much oxygen?
So yes, there are problems with too much oxygen, which we would call hyperoxia. So when delivering high levels of oxygen, the effects are different depending on the patient population and specifically the patient age. In infants and newborns, delivering high levels of oxygen can actually something called retinopathy of prematurity, which can cause vision problems and potential blindness in babies. So that's definitely one complication from delivering too much oxygen in infants. In adults, you can also have problems with having too high fraction of inspired oxygen. And so some of those complications include actual oxygen toxicity, which usually refers to the development of things called free radicals, oxygen-free radicals, and these are elements that are actually injurious to cells. So they can lead to cell injury, cell death, and therefore tissue injury and tissue death. So having very high levels of oxygen for several days can also cause lung injury. So the goal, especially if you have somebody on a mechanical ventilator, the goal is to get their fraction of inspired oxygen down to 60% or less as soon as possible if you're able. If the patient still requires high levels of oxygen, you need to utilize all the other techniques to improve oxygenation, but you would continue to give them oxygen even if the time course has been a long time. So you really base it on the clinical needs of the patient. I would just maybe also comment that this harkens back to the question about hyperbaric oxygen. Hyperbaric oxygen can deliver higher levels of oxygen. It's usually done in a chamber, and it's usually limited in time for those reasons. It's a high requirement of oxygen. It's delivered under pressure, and so it can also lead to complications of having too much oxygen. So in general, you want to give a patient enough oxygen for the desired SpO2 reading on the pulse oximeter. So for most adults, we would say that's around 90. But note that in the Lightbox triage tool, that goal is 92%. And again, when we talk about giving too much oxygen and not being wasteful, we don't need necessarily an SpO2 of 100%. We can actually be happy as long as it's above 90 to 92%. So we don't have to target 100%.
Okay, and on our website, there's also an article. It's harmful effects of hyperoxia. And this study was done in ICU patients in Canada. And so you can just see the chart of, first of all, these are all these review articles where it says hyperoxia generally showed an increased mortality and greater increase in case fatality in many patients that were studied. It can also lead to all of these complications: pulmonary damage, apoptosis, oxidative stress, vasoconstriction. So it's not always a good thing. And I think we could end with one of the panel, somebody asked, are there new updates or treatments for COVID-19? So Stanford has an external page, COVID-19 ICU task force. And this was on the therapeutics and clinical trials. And currently, still the mainstay of treatment for COVID-19 is supportive therapy. So that's lung protective therapies, proning the patients. And then it goes through, we have a clinical trial, and there's potentially other therapies, but nothing is currently recommended. Do you panelists have anything else to add to that?
I don't have anything more to add to that. I think that the supportive care seems to be the best thing. Of course, we enroll patients in clinical trials every day, and some patients they work and some patients they don't. And it's hard to determine without very large studies and lots of patients being enrolled in the studies. You can't really draw any large conclusions for that. So I think it comes down to our basics and how we treat ARDS and how we treat a lot of pulmonary pneumonia, just supportive care.
Yeah, I would actually agree. I think it also depends on the institution or facility in which you are working. Because COVID is, the information and evidence is moving so quickly and we're learning so much every single day, the recommendations change very often. And so it can seem quite confusing on how to manage these patients. But managing them as you would any other ARDS patient seems to be the most helpful thing that we can do. Early in the outbreak of COVID-19, we were intubating patients much earlier. And we have now seen that the mortality rate of patients that are intubated and placed on mechanical ventilation is very high. So if we can avoid mechanical ventilation and intubation, then we do try to use other supportive interventions such as high-flow nasal cannula or non-invasive mechanical ventilatory support such as a BiPAP or CPAP mask. There have been a lot of therapeutics that are mentioned and being evaluated. As of today, and again, things change every day because we're learning more and more about this disease. As of today, the only things that have shown any sort of positive outcome difference is remdesivir, which is sometimes available, sometimes not available. Remdesivir did not have a difference in mortality outcomes, but it was supportive of decreasing the amount of time that patients were in the ICU and on mechanical ventilation. The other, and so you will see in our setting and in some facilities, not all facilities, but in some facilities, patients will have access to remdesivir. So that is something that we are seeing more people using as an intervention. The other is dexamethasone. This is relatively new information. And I think we are seeing an increased use of dexamethasone in COVID-19 patients. And I think that we have to be careful with the use of dexamethasone. It's only shown benefit in patients that were already receiving supplemental oxygen and or mechanical ventilation. So it's usually shown in positive impact on patients that were more severe in their disease. As most of you probably recognize, steroids, of which dexamethasone is one of several different types of steroids, do have complications. So when you're using steroids, you have to more closely monitor patients' blood sugar. Using steroids has been associated with an increased rate of infection. Using steroids, especially late after 14 days of ARDS, actually had a worse outcome in a previous study. So some of the information is a bit conflicting, but you might see people using dexamethasone in patients that have more severe COVID-19 ARDS related symptoms. There are other facilities that will use convalescent plasma. To date, there's no information that supports the use of convalescent plasma. To my knowledge, again, tomorrow it may be different. And then a lot of other medications that I'm sure you've seen mentioned in the news and the media. And unfortunately, we don't have the evidence. COVID is moving faster than the evidence. So a lot of this is to be determined still.
And then there was the question, is sedation relatively contraindicated in patients who are not on mechanical ventilation?
So I think that's a really excellent question. The patient's level of consciousness and ability to participate and cooperate in their care is hugely important on how well they do. And this is true for several reasons. One is any sort of sedative type medication is going to be of a certain class of medication. So a benzodiazepine, an opiate, a hypnotic, and if you're lucky enough, you could have something like an central alpha 2 agonist. But most of the time, they're going to be benzodiazepines, hypnotics, or opiates. And all of those drug classes will decrease the patient's respiratory drive, which is not what you would want to do in this situation. The other concern is if it makes the patient more somnolent, they may not be able to self-prone, which is one of the things that you can do with patients on oxygen delivery devices, is ask them to turn over onto their stomachs, so into the prone position. And so patients that are altered, either somnolent or agitated or delirious, are less able to be cooperative with their care. One other type of sedation that may assist and not decrease respiratory drive would be something like Haldol. So I'm not quite sure how available that is. But again, the patient might be a little too sedated and less able to participate in their own care and or breathe deeply and calmly as needed. So giving sedation is a very tricky thing to do because it might make the patient less agitated, but it might precipitate worsening respiratory failure. And then you have to escalate your level of support using non-invasive mechanical ventilation, or more likely intubation and mechanical ventilation. So sedation, it's not a contraindication. You have to look at each individual patient and each individual situation to determine. But it's something that I would do with extreme caution. I don't know if Diana has something to add to that, or, okay.
No, that's 100% what I would say.
Yep, it depends on the individual patient and the circumstances. So does anyone else have any other questions? Again, we will post all of our resources on the website. We will post our chat as well. And thank you for joining. See you next week.
Hi, this is Alana from Assist International. Just to close out the session today, I would like to extend a sincere thank you to all of our panelists for sharing their time and expertise. A sincere thank you to all of our participants for joining in and engaging with the material. And of course, a thank you to our funders, Grand Challenges Canada, the ALMA Foundation, the GE Foundation, and the UBS Optimus Foundation. In the next couple of days, Assist International will be emailing out a follow-up email. This email will include a link to the Learn World Resource Center, which, as Dr. Strowd mentioned, will include links to all the modules went over today. It will include links to the session recordings, including translations in Khmer and Vietnamese, a copy of the question and answers that were covered today for your reference, and a link to a feedback poll. Please do take the time to complete this poll. It only takes about 2 minutes to answer the questions, and we use these answers to improve upon our programming. Finally, as shown on the screen, we do have a WhatsApp group set up. This is an opportunity or a space for you to ask any follow-up questions you may have of our panelists after each session. And to join, you can join using the QR code on the screen, but we will also email a quick link in our follow-up. And finally, if you have any questions, please reach out to us at echo@assisinternational.org. Thank you.